how are you?
Hi.
My name's Shane. I'm going to be your nurse practitioner today. What brings you in?
Hi, I'm here for an annual checkup.
Okay, perfect. So during this, we're going to test 3 systems. We're going to go through your neurological system, your musculoskeletal, and your abdominal, if that's okay with you.
Yes.
So in the beginning right now, I'm just going to do a mini mental status exam on you, and I'm just going to test your orientation and a couple of other things, your gait, your coordination, your movement, your sensory throughout this neurological exam. So can I have you state your name, date of birth?
Jen Sitnary, birthday is 3372.
Perfect. And do you know where you are right now?
In my house.
Perfect. Okay. And who's the president?
Donald Trump.
Okay. And what year is it?
2017. I keep wanting to say 19. 2017.
Perfect. Not a problem. All right. So I'm just going to test some cranial nerves for you. Right now I'm going to do 2, 4, and 6. We're going to test your cardinal gazes. Go from there, and then we'll just work our way down. Okay. All right. So I'm just going to have you follow my finger with just your eyes. Good. And I'm going to test for convergence. Good. And I'm going to test your peripheral vision. So when you see my hands, let me know, okay?
Okay.
Good.
Okay. Okay.
Good. And can I have you smile for me? All right. Stick your tongue out and move it side to side. Perfect. Puff your cheeks for me and raise your eyebrows. Good. Can you shrug your shoulders? Good. I'm going to have you close your eyes, and I want you to tell me if you feel me, okay? Good. And can you lift your arms up for me? Good. Keep your eyes closed. Do you feel my hands?
Yes.
Does it feel equal or different?
Equal.
Good. Grab my hands, give me a squeeze, pull me, and push me. Good. All right, I'm going to have you relax, and I'm going to test your legs. Can you bring this leg up for me? Good. And this leg. Good. Can you bring both legs up for me? Good. Push down and flex up. Good. I'm going to do some sensory testing on you now. So I just want you to tell me if this is sharp or dull, okay? Close your eyes.
Dull. Sharp. Sharp. Dull. Dull. Sharp.
Good. Keep your eyes closed. Can you put one hand out for me? And I'm going to put an object in your hand, and I want you to tell me what it is.
Rubber band.
Good. And next one.
A coin.
Good.
Paper clip.
Very good. And keep your hand up. And I'm just going to draw an object, and I want you to tell me what it is.
A circle.
Very good. I'm going to have you open your eyes. I'm going to have you occlude one ear for me. And I'm going to whisper something in your ear, and I want you to tell me what it is.
Apple.
Okay?
Banana.
Perfect. All right. I'm going to have you stand up for me. And can I just have you walk normally to that door and back? Very good. On your way back, can I have you walk heel to toe? Good. And on your way back, I'm going to have you walk just on your heels. Good. And on your toes. Perfect. I'm going to have you have a seat. Can you grab my hands? Give me a nice squeeze. Perfect. I'm testing your strength right now. That's 5 out of 5. Perfect. Relax. At this time, I would test her range of motion, and I would also test her deep tendon reflexes. However, as we progress into the musculoskeletal system, that's where I will be testing those functions. Next, I am going to, I think that's it, actually. So next, we're going to progress our way into the abdominal exam. So normally, Jen's here right now for an annual assessment. Normally, if we are doing an abdominal assessment, it's because a patient's coming in with a complaint. Which would utilize old cart, looking at the onset, the location, the duration, aggravating factors, relieving factors, when did it start. However, because this is an annual assessment, we are just going to continue our way through looking at more of the system as a whole. So I'm just going to continue my assessment first. As far as the abdomen goes, I'm going to make sure that my patient's covered. And I'm just going to expose the abdomen as I need to, maintaining patient privacy. As far as the abdomen goes, you'll want to always make sure that you look first and then listen, because you don't want to promote any bowel sounds that may be occurring that aren't naturally there. So I'm looking, I'm making sure that it's symmetrical. I'm not looking for any bulges, any masses, any discoloration. You could look for the Gray Turner sign, the Collins sign, look for any guarding. So right now, this abdomen looks normal. So my inspection's over. I'm going to now be auscultating. So I'm just going to listen, and I'm going to work my way through each quadrant. And as I work my way through each quadrant, I want to keep listening until I hear vowel sounds. And you can listen up to a minute. Perfect. Vowel sounds are there. They are not hypo or hyperactive. They're normal vowel sounds. I'm going to now progress my way into palpating, percussing first, and then palpation. So I'm going to percuss the quadrants, looking at the tympani and the sounds that are present. And as I'm on this side, I'm going to be looking at the liver span, percussing my way at the second intercostal space, moving down. Looking for changes in sound as I hear them. And while I'm over on this side too, I can also reach over and also take the spleen. Percuss the spleen. As far as my percussion's done. I got a liver span. In this indication, I could say, for example, it's 7 centimeters. I'm now going to promote myself into palpation. And I'm going to start with light. I'm going to notice my patient. I'm going to look for any grimacing, any guarding. And now I'm going to move on to deep palpation. Perfect. No guarding present. And now I'm going to look into organs. So like I said, over here is a spleen. I'm going to assess the spleen. I'm going to have the patient take a deep breath in. As they exhale, I am going to either do one of two ways. I can hook, or I can take my hand back here and press down, looking for the spleen. In this situation, I'm going to do the hooking method. I'm sorry, for the liver, not the spleen. So can I have you take a deep breath in? And exhale. Good. And I'm looking to feel the liver. Okay. I can have the patient do the same thing over here for the spleen. And exhale. Good. As far as kidneys, I'm going to take my hand and go towards the back. Same thing. I'm going to have her take an inhale, an exhale, and feel. Good. Okay. During this assessment, I'll also be asking questions about bowel movement. Is there any nausea, vomiting present? Typical eating habits, bowel patterns, bowel habits. I'm looking for any complications or any indications that I need to assess also. Going back for auscultation, I also need to look at the abdominal, the AAA, abdominal aortic aneurysm. I'm sorry, abdominal aorta. You know what I'm saying. I'm going to listen for any breweries. I want to make sure that I hear none of those, because that would be an indication for something that I need to investigate or something that warrants further investigation. In this situation, she's clear, and that would precede our abdominal, and we're heading to musculoskeletal next. So previously during our neuro exam, we look at range of motion and we look at dependent reflexes. However, because we were doing a musculoskeletal exam, we're going to group it all together with this. So I'm going to be looking at abduction, adduction, flexion, and extension, working my way down from the neck all the way down, looking to make sure that she can do all the movements. There's no pain, there's no deformities, there's no swelling, there's no crepitus, there's no dislocations, and we're just going to proceed right into the exam. So I'm going to start with the neck, so I'm just going to have you go like this. Good. Perfect. And I'm going to have you shrug your shoulders up. Perfect. And I'm also going to be looking at the jaw for TMJ, so I'm going to be feeling. All right, I'm going to have you clench your good, and open your mouth. Good. Perfect. So working our way down now, I'm going to be looking at the arms. Can you come up? Good. Push against me. Good. And pull up. Good. I'm going to have you stand up. And can you raise your arms out? Good. Up. Perfect. Back down. And then I need you to cross. Good. I'm looking at the lateral side. Okay. I'm going to have you sit back down. I'm going to be working my way back, and I'm going to be looking at her back, starting right up here at the spine. And I'm going to be looking for any deviation, any sideways, but working our way down. Cervical, it looks straight, so we're testing for scoliosis, which I don't see any. We're going to come back over. I'm going to now be working my way into the hips. I'm going to have you turn over. Okay. Yep, you can stand. Turn over. Good. Good. I'm going to have you bring your legs up, and bring it over. Without falling. Alright, I'm going to have you sit back down. Bend over. Good. Touch your toes. Good. Okay, and come up. Okay, and then extend backwards. Good. I'm going to be feeling. Good. I'm going to be looking at our hips, looking for symmetry. Perfect. And I'm going to have you sit back down. I'm going to be looking at your legs now. Can you lift this leg up for me? Good. And this leg? Good. And can you move it side to side? Either way is fine. Yep, I'm just looking to see if you can control movement. Very good. Okay. And I'm going to now be looking at your ankles. Can you push down? Good. Flex up. Good. And can you rotate your ankles? Very good. Alright. Now I'm going to be working my way into deep tendon reflexes, assessing the brachioradialis, the bicep, the tricep, the patellar, and the Achilles. So unfortunately we don't have our hammers, so we're going to make do with this. So first I am going to test the tricep. I would look for movement. I'll be looking at the bicep, brachioradialis, working my way back to the patellar. Good, and then I can either have her lay down or I can have her come up this way and test. Perfect. Alright, I'm going to have you lay back down. Alright, I'm going to have you lift your legs up. Perfect. And next leg, good. Alright, I'm going to have you turn around. And I'm going to be looking at you this way today. You can bring your legs up. Very good. I'm going to have you stand up. And one last time, I'm just going to be looking at gait. And looking at the spine. And I see no abnormalities, no dysfunctions, there's no pain present. And that would conclude our musculoskeletal exam. Okay, so this is going to finish our video. So now, because this is more of an intimate examination, we are going to be talking about the male genital and prostate exam and the rectal exam. I'm going to start first with the male genital exam. So prior to this, you want to make sure that you're obtaining a focused history, including any concerns or symptoms that the patient might be experiencing. But most importantly, you want to make sure that you're protecting patient privacy, you're making them feel comfortable. This can be uncomfortable for both the practitioner and the patient, so you want to make sure that you guys are both comfortable with what's going on, and you want to ensure that the patient is comfortable the entire time. So you want to make sure that the patient is either standing or lying supine when you're doing a general exam, but when you're checking for varicelles, you want to make sure that the patient's standing. The gown should cover the chest and the abdomen and expose the genitalia and the inguinal areas, placing the draw seat at the mid-thigh, and wearing gloves throughout the entire examination process. So each step is going to be explained to the patient what you're doing and what is expected throughout the exam, making them feel comfortable ultimately, but also making sure that you're getting a thorough assessment in. So in the beginning, you want to inspect the penis, you want to look at the skin on both the ventral and the dorsal surfaces, and you want to look at the base, looking for any excretions or inflammation, looking at the pubic or genital area. You want to look to see if there's any lace or scabies, look for any retractions, and this is especially essential if you're looking for cankers or carcinomas. Smegma is a cheesy whitish material that accumulates under the foreskin. This is normal, and you want to assure the patient that this is normal, especially when you're looking at the gland. You want to look for any ulcers, scars, nodules, inflammation. Look at the urethral meatus, inspect its location. And then you want to make sure that you're looking for any congenital ventral displacement in the medius of the penis. Compress the gland and gently notice any discharge. The patient's having discharge. You want to make sure that you're collecting it and you're getting a culture for it. At this step, you're going to go into palpation. You're going to use your thumb and your first two fingers, and you're going to palpate the shaft of the penis. Note any indurations, abnormalities, any tenderness. If you're retracting the foreskin during this part, you want to make sure you're replacing it before you're proceeding onto the scrotum, especially along the process of this examination. Any induration shows of the penis suggests that there might be a urethral stricture or carcinoma, as I mentioned earlier. Any tenderness might suggest any periurethral inflammation of the stricture. So now you're going to go into the scrotum, you're going to inspect its skin, you're going to lift the scrotum and inspect the posterior surface, note any lesions or any scars. You want to note the pubic hair distribution. Inspection might reveal maybe a scrotal nabii, hemanogiomas. But most importantly, you want to make sure that you're looking for any STIs, any herpes. You want to make sure that you're swelling, inspecting the swelling, any lumps, any veins, any bulges or matches, and most importantly, if there's any asymmetry. Especially because it's normal for one testicle to be bigger than the other, so we want to assure your patient that that's okay. One might hang down lower than normal than the other one. Now you're going to palpate the testes and the epididymis between the thumb again and the first 2 fingers. The testes should be firm but not hard. They should be descending, symmetric, non-tender. They shouldn't have any masses on them. Painful scrotal swelling is present in acute epididymis, acute orchites, and then torsion of the spermatic cord or strangulated inguinal hernia. Any strangulation can be an emergency because it's cutting off the blood flow, so you want to make sure that you're assessing for that. You're going to look at the testes, like I said. You're going to look at the size, the shape, the consistency. You're going to put pressure on the testes. You're going to look for any nodules. You're going to palpate the spermatic cord between your thumb and your fingers and the epididymis and look for the inguinal ring. Note any nodules or swelling. And you just want to make sure that you're getting a thorough assessment with the testes in. Especially with the hernias, you're going to be looking... you're going to have the patient go back to either standing or supine, and then you're going to look in regions of the genitalia for any bulges or asymmetry. You're going to palpate. You're going to place the tip of your dominant finger and the anterior inferior margin on the scrotum, and you're going to do a thorough assessment just above the lateral to the pubic tubercle. You're going to ask the patient, most importantly, to cough and palpate the bulge and the mass, and then you're going to use the same process when checking for any other the other side for the femoral hernia. When this exam is complete, you're going to move on now to the rectal exam that we're going to talk about. And at this point, I would definitely change my gloves, educate my patient, and then continue on into the rectal exam. I'm going to choose a suitable position for them. They could either be lying or standing. Left side usually is best with the hips flexed. You're going to, again, drape the patient, but most of this should already be done because you're going from one to the next. Explain everything that you're doing, and then inspect the sacral, coccygeal, and peritoneal areas for lumps, ulcers, inflammation, rashes. The skin normally is going to be pigmented and somewhat coarser in that area compared to the buttocks. And then you're going to palpate any abnormal areas for more lumps and tenderness. Looking for hemorrhoids, warts, herpes, cankers, carcinomas, again, linear cracks or tears might suggest an anal fissure. It could be from a large hard stool, IBD, or an STI. You're going to examine the anus and the rectum. You're going to lubricate with your gloved index finger and palpate the anal canal. You're going to have the patient bear down and place your pad of your finger over the anus and the sphincter and have them relax while inserting the fingertip in the anal canal. But most importantly, you don't want to make sure that you're forcing anything in there. It should go through naturally. You want to point your finger up towards the direction of the umbilicus and explain what you're doing. The patient might have an urge to defecate. You want to explain to them that this is normal, that this is a normal feeling, and then if you feel the sphincter tighten, pause and reassure the patient to continue once you're relaxed. Sometimes any severe tenderness can prevent an entry in the examination. Like I said, don't force anything. You want to palpate the rectal surface, insert your finger into the rectum as far as possible, go clockwise and then counterclockwise. Note for any masses, irregular borders, suspicious rectal cancers. You want to leave your index finger in there and explain through the examination that you're going to be looking at the prostate now, and this might prompt an urge to urinate. Sweep your finger carefully over the prostate, identifying the lateral lobes in the groove. Look at the shape, the mobility, the consistency. A normal prostate is going to be rubbery, non-tender. And then you want to withdraw your finger and you either want to wipe the anus, you either want to wipe your glove from the anus or have the patient wipe themselves to look for any fecal matter. It's probably more comfortable for the patient to wipe themselves. For the females, the rectum is usually examined after the male, after the female genitalia. That's why we were doing the genitalia first. However, we're really focusing more on the male exam right now. When you're doing the rectal exam, though, you want to look for any abnormalities. These could include external or internal hemorrhoids, prolapse of the rectum, any anal fissures, any polyps, rectal shaft, any cancers, anal rectal fistulas like we talked about. And then afterwards, you want to make sure that you are making the patient still feel comfortable. You want to make sure that you're educating the patient about what happened, what you're doing, why you're doing what you're doing, and most importantly, you want to make sure that you're educating them that they should be performing a self-examination once a month. And then also, again, like I said earlier, let them know that one testicle might be slightly larger than another, but all in all, this is normal. But this will conclude our exam. This will conclude the video. So as we talked about earlier, we went over the neurological, abdominal, musculoskeletal exam. What I did not mention earlier was when you're doing the abdominal exam, you want to make sure that you're following up with the genital urinary system for the males and the females. And this will conclude our video.